He organizes the Institute for Healthcare Advancement's annual Health Literacy Conference, has really written numerous articles and lectures nationally on health literacy, and is a member of the Roundtable. Michael, I'll let you introduce the panel.
Great. Thank you, Bernie. Appreciate that. And I guess Andrew might say this is the second toughest session of the day, is the one just before you and dinner and whatever you wish to sip on a little bit later today. So hopefully this will be productive and allow some input from everybody else here. We have a really great panel, by the way, for this last session. Starting to my immediate right, Ms. Maureen Daniels, who's the Director of Wellness and Community Health at Berkshire Health Systems, a small community health system nestled in the Berkshire Hills of Massachusetts, which offers wellness programming for its staff, spouses, community businesses, and the community at large. There, she has the privilege of designing and implementing programs to improve the health literacy of community members. Next, we have Michelle Erickson, who's the Executive Director of Wisconsin Literacy, Inc., a coalition providing support and leadership to 75 local literacy agencies. In 2005, she began working in health literacy by directing small community-based projects with local literacy agencies to improve health understanding, and by 2010 had launched Health Literacy Wisconsin, a division of Wisconsin Literacy. Next, we have Caroline Young. She is the Executive Director of Nashville Health, an initiative focused on improving the health of the citizens of Nashville-Davidson County. Nashville Health is chaired and was created by former U.S. Senate Majority Leader Bill Frist in an effort to address area health equity issues and ensure Nashville continues to be a great place to live and work. And finally, but not least, we have Dr. Bill Elwood, the OpNet Health Science Administrator in the National Institutes of Health, Director's Office of Behavioral and Social Sciences Research. That must be tough to rattle off at parties 10 times in a row when you're, okay. OBSSR, as it may be more shortly referred to, integrates behavioral and social sciences research within the larger NIH research enterprise and leads emerging topics across the agency. Without any further blathering from me, I'd like to jump right in. Our mission here is to take some of the lessons from today and some of the rich information that we've enjoyed today and provide some next steps, or where do we go from here, for the folks in the room and for those listening online. So I'll toss up a little bit of a softball question here for you, but I want to add a little twist to it. Our question is, what are the challenges that we're facing in creating and implementing effective community-based health literacy efforts? And in addition to the challenges, I would like the panelists to also provide some potential solutions as well. And the more creative, the better, especially in terms of how we actually get over some of these things. And as we're talking about challenges, of course, one of the main ones that we all run into is funding and resources. That's kind of our main one. But we want to talk about some of those other little more subtle issues. These are ones around trust, buy-in, community, integrating into that particular community, value, cultural language issues, engagement, those sorts of things. So I'm going to open it up to the panel to answer that first question. Michelle, do you want to start? I may put you on the spot.
No worries. Thank you. When I thought about this question in terms of challenges, I think the first three things that came to my mind. The first one was infrastructure of community-based organizations. And having worked, let's just say a lot of years in community-based organizations, I think it's about 30 now, I feel that infrastructure is one of the great challenges of organizations that work at the community level to keep, to attract and sustain quality employees that are engaged in the community work or finding that right balance between that engagement and not being burned out from the work that they're doing. So, attracting adults with passion, and again, the ability to sustain that kind of work over a long period of time, sometimes in working conditions that are just challenging. Health benefits are sometimes a luxury for many of the community-based organizations we work with, if they're there at all. And, pay is often lower than what they might have at a for-profit institute doing some of the same kind of work. So that's one challenge. The other thing I thought of, secondly, was buy-in and trust. working with communities. I think that was one of the first things that we have to establish when we work with our community partners. Wisconsin Health Literacy, well, Wisconsin Literacy has been actually providing support, training, advocacy work, and capacity building for our members for over 32 years now. And so we do have a really strong relationship around trust and buy-in, and I think our programs understand what we are trying to do. But that is also, that's not what is always most important, that understanding of what our communities need, so that they're telling us as opposed to us telling them, which has been covered pretty well today already, is just another really important factor. And then culture and language, and the challenges of working in multi-linguistic environments, multicultural environments. I think of one of our interventions, Let's Talk About Medicines, where we had in one room of 35 to 40 people, we had 6 translators, 6 languages, going on at the same time, and trying to make sure that the information that we wanted to share was delivered in a way that was accessible and understandable for everybody that was in the room. And so those are 3 things I think that come to mind right away for challenges in the environments in our communities that we work in.
Hi. You're all still awake, so that's pretty impressive at 3:15. So in the Berkshires, we're a pretty small community organization, and one of our biggest aha moments in the last few years is really, we've been doing community outreach for about 15 years, but the clinical way, the hospital way, and in the last few years really re-looking at our verbiage and what we're saying to people and how we're approaching the conversation around health literacy. So similar to what Michelle said, is not our agenda, but what is their agenda. So that's a really important one. Being creative with our solutions. So looking at community health workers versus nurses. So it is more sustainable. It's a more sustainable model out in the community. It's also meeting people, again, where they're at. Having community health workers who live in the community in the neighborhoods. And then I think the other piece around partnering in the community is partnering with the correct folks. Similar to YouTube videos, there's lots of information about health information and health literacy, and you can drink this smoothie, but it's not always correct, so being very careful to vet those partners and who they are, so that they are best practice and clinically evidence-based models, and so that they will be around as long as you will be around, and they're not going away in 6 months and you're left without that partner. So it's some of the things that we're looking at.
Good afternoon. I'm delighted to be here today. I represent a very young organization, Nashville Health. We are almost 2 years old, so I've learned quite a bit from the discussion, and so much of the comments have resonated. So thank you for the opportunity. When I thought about this question, and it really, my response kind of builds on what has been shared today, and we seek to create a cross-community dialogue and awareness about health in Nashville. So groups that haven't come to the table before will get involved. And this has involved a lot of listening, a lot of learning, and understanding where these very many layers in the community are, especially the business community. And as I've learned, each layer really has a different vocabulary related to health and medical issues. And so there's a constant translation act that I'm doing, and asking a lot of questions as far as, are you saying what I think you're saying? Are we talking about the same thing? And let alone what the patients or the actual community members, the vocabulary that they are using. An example of this happened just last night. I was at a dinner for women in healthcare in Nashville, and this was a businessy crowd. And I'm popping around, networking at the different groups, and they're talking about the federal healthcare issues of the day. And one group mentions the payers. And I pop over here, and the other group mentions health plans. And the third group I popped to mentioned third-party payers. Now, I know that those are all the same things, but does everybody else know that? And it was just a clear example of the multitude of terms that we use in this work. And I guess a creative solution to kind of dig in is a simple one that I encountered recently, and that's the telephone. So I was encouraged by someone who'd worked in community health in our neighborhoods for a long time for me to call this individual and get to know him, because he was a real gatekeeper. And I thought, I've got to use the phone? Can't I just email him? Who uses the phone? And so I sat on it for a few days, frankly, because I couldn't email him, and I guess I was being lazy. And I finally picked up the phone and I called him and gave him a real quick breakdown of who I am and what we were up to, and he was wonderful. And we had a wonderful meeting, and we're going to be working together. But that's so much for a creative solution, but there you go.
I mean, I think that gets into the issue when we talk about folks who are digitally native, and that's kind of your first default response. But yes, no, sometimes the old ones are good. Along the lines of challenges, before we move on, I want to talk a little bit about, we've been talking about community-based initiatives through a health literacy lens. And there are obviously quite a few community-based initiatives that don't necessarily have a health literacy lens. And if we, as this community, wish to engage in that, how do we bridge that gap between groups that are doing great work within the community, but helping to infuse this notion of health literacy into that? And I'm sorry, I know that wasn't an exact one that we had talked about before, but can anybody speak directly to that, where we make sure that that health literacy element component is in there with groups of folks with whom who don't necessarily work within that domain or that framework?
I'll give this a try.
Thanks for rescuing me.
So I think trying to make sure that the communities in which we work with are, in terms of health literacy skill sets.
Or, starting with awareness.
Right. So, first of all, awareness. And I wanted to reference Cynthia's the paper that pointed out how much knowledge was a factor or an evaluation criteria that a lot of these interventions used. And I thought about our own interventions, in which we do a lot of pre and post measure of knowledge, and that is something that I think I appreciated that your reference that it is valuable, because when we work with different populations, we started out with let's talk about medicine for seniors, and when we worked with let's talk about medicine for refugees, we had to go back and define what is pharmacy, much like Dr. Wellington's comment about the use of mammogram, and so there is a lot of time spent on that. So this knowledge and understanding is something that I think was really important that we addressed. But if you think access, understanding, and using that information, I mean, one of the things that we want to do, not always to the end user, but to the communities, the program directors that we're working with, is provide their ability to sustain the effort, to have these skill sets that are shared with the community, and that they're trained in delivering those skill sets, the access, the understanding part of it, and then how is the community going to use that information. So I think we try to think about when the funding's over and we walk away, what does that look like? What are those health literacy skills the community will take away, not just the end user, but the providers?
Thank you. Which actually is a great segue into our next question, which talks about how do we, when we create these community health literacy interventions, going in and doing it and then saying, the helicopter approach, as we said, is okay for that particular population. If it works, that's wonderful. But I'd like you to talk a little bit about sustainability, scalability, and portability to other communities. How do we address those particular issues as we're designing these interventions on the front end, so that we not only tailor it to the group with whom we want to interact, but that we have something on the back end that can be useful in another community, at least as a basis for tailoring to another community.
Well, first, I'd say if it's an application that starts at the National Institutes of Health, any standing study section that is community-oriented is going to look for, invariably is going to look for a process evaluation plan and a set of deliverables that its community partners can use to sustain the program if indeed it's found to be effective and if the organization believes it is worth while for them to continue wherever they are. My agency also is heavily, if you want to keep that science trajectory going, there is dissemination and implementation research, which has not only grown across the agency, but also now we have partnered with Academy Health in an annual conference as well as training institute to help current and existing, well, current and existing are the same, but also emerging researchers who can look at the science of diffusing and tailoring and scaling up large-scale interventions. But immediately, proactively, and practically, first, I'd recommend getting a librarian, because we've learned today that they are the people who know how to make things happen. And they don't make things, as we learned today, they don't make things happen alone. They make things happen with, not only for every member of the community who wants to show up, but also with other community-based organizations. And that's where I think that we can see immediate action take place, because so many community-based health-oriented organizations, we heard today people say, oh, we've been doing health literacy, we just didn't realize that's what it was, right? And there are, if you are in rural areas, there are AHEC, rural health centers, there are federally certified and non-federally certified health clinics. There are churches. There are nonprofit health literacy organizations. There are all of these community-based organizations that are doing good work, perhaps all on their own, or maybe with one community partner. And Michelle, or Maureen, I believe it was one of the two of you said, you know, you need to choose the right partner. There are so many great partners out there doing great work who may not necessarily be talking or partnering with one another now, but when they join forces, can complement their primary care clinic with perhaps an outpatient mental health practice for chronically mentally ill people with housing solutions, which we talked about this afternoon. So rather than perhaps looking for buy-in, I would look for giving, because when community members and community-based organization look to each other and give one another what they have, it's like stone soup. They can provide much better resources to perhaps more people, or leverage those resources to reach greater populations than they ever do alone.
I'd be lying if I didn't admit that I'm a little bit jealous of Ariella's 16 years of funding from Johnson & Johnson to carry out the work of the Head Start programs, in the sense that when I think about scalability and portability and the evaluation that over years you're able to achieve, which I think speaks really loudly to sustaining an effort and expanding an effort in different places. So I think that is really one thing to think about. And if, you know, often funders are, you know, sometimes they have to move on to the next thing or the next issue that's becomes a priority. And so that's a challenge. But I think thinking about the capacity of the organization and the community that you're working with, the providers that are working within that community, do they have the capacity to report, to evaluate, to measure, and to get that information back to you? That's really important, because without that, it's hard to make the case to funders, that this intervention is really worth a second or third or fifth year of funding, if you will. So that's one of the things I think about. And then also, I feel like sustainability and portability, if the community itself, again, I know we've talked about this, but if the need is articulated from the community, the motivation to sustain that initiative is going to be so much greater, and that your work is less, because we get calls back from our communities that we're working with, and will say, hey, are you going to do that again? Our learners are asking, or our clients are asking, are you coming back with that intervention? And it's hard when you don't have the funding to say we're done, and that's why we think about this sustainability piece, and what is it that we're leaving with that community when the funding's over and we're not part of that intervention? What are the tools that we leave them with to continue it on?
So along with the sustainability, I think is part of looking at the community as a whole. And we do a lot of work in the community and businesses. We sell wellness programming into businesses in the community. So when we're designing those programs, they're easily transferable into the community. So we take the same program that we do for General Dynamics into the jail system. So it's paid for essentially by that contracted company that wanted our business. But then we have spent the money to design and evaluate and assess it, that we can then easily transfer it into a community-based organization. So when you can partner that way, when you can get stakeholders in the community, whether they are within the business district or within the government system, whether they are with the churches, whatever it is, that you can have some sort of buy-in that brings some different money to the table and get creative that way, that helps sustain. It's a community effort here, and then that helps support the role for sure.
You guys are just giving me the best segues here. Thank you so much. You're making my life so much easier. So our next question talks about potential areas for collaboration with other community-based programs or other community-based entities. And so our question is, with whom can community-based health literacy practitioners build partnerships? And Bill, I thought your metaphor about the stone soup was actually perfect here, because everybody has something that they can bring to the party to make a contribution. But then also, I think we can flip that over and take a look at other entities in the community and say, and ask them, what are your goals within this community? Are you, when we talk about sustainability for subsequent funding for programs, do certain entities that could provide funding just want to be associated with some of these programs, and can we approach them for funding? Do other entities have other associations or mandates or requirements for being in that community, being part of that community, that they want to be able to contribute? So I'm going to toss this out and ask folks, just as an aside, when I was looking at the presentations earlier, Leslie had at least 24 community partners on one of her slides. Katina, I think you had almost 50 on the slide that you had. And I thought, oh my gosh, now that's some creativity. So let's talk a little bit about who some of those partners are. How can we think a little bit differently to partner with folks to achieve the mission of the study of the intervention, and as well as serve that company, the community members on a longer term basis?
I'll jump in. As an organization, we exist to form these partnerships, or to help the formation of these partnerships across the community, kind of acting as a connective tissue, if you will, in Nashville. And I think we've seen a lot of success when we have come to these discussions with humility and with open-mindedness, and building on just what you said, having spent some time thinking about what's important to the person across the table from me. A specific example would be in our conversations with the Chamber of Commerce, and encouraging them to get involved in our efforts, when we explained that the health of the community is really an economic development issue. Our community is not going to continue to be successful and grow from an economic perspective if there's not the promise of healthy, productive workers. And it didn't take long for that to ring home. So that was an example of us kind of thinking strategically about partnership building.
I'll just add to that quickly. This comes from our communication specialist, Carrie Wiscalo, we're working now with a dementia and Alzheimer's intervention, and thinking outside the box, it wouldn't have occurred to her probably to work with a group of pastors, but it was one of the board members at a literacy agency that said, you know, I know that the pastors are working with patients experiencing dementia and Alzheimer's, and when we were able to train that group of individuals, or that group of pastors, then, you know, again, just another community or population that we wouldn't have reached right out to as a partner in thinking about where we were going with this project. But senior organizations, homeless shelters, lots of these have been mentioned, you know, benefits counselors, FQHCs. There are numerous partners in the community. And with libraries too, right now there's a national action plan that the American Library Association and Pro Literacy has put together to look at how libraries and adult education work together on meeting the needs in the library of adult learners. And so there are 7, I think, strategies and specific steps, and you can find that action plan online, and we're really trying to look at ways we can implement that among our programs.
Yes.
I'm going to start with something rather practical, but did anyone read the Washington Post yesterday? The Health and Technology Health and Sciences section. Okay, thank you. Cindy, then you read about, I'm speaking of seniors, then you might have read about grandmothers in Harare. Okay, I got a head nod. I'm up. Those of you who haven't have missed out on a translation of an article, I think from the Annals of, no, not the Annals of Internal Medicine. That's not the narrative. This is the one about mental illness in Zimbabwe, where I don't know, I think there are, 15 million people and 14 psychiatrists in the entire country, maybe less. And mental illness is, mental malfunction happens in Zimbabwe, but Zimbabweans don't have, it's not in their cultural reference, so they don't have a word for mental illness, but they do have people with problems who are either wandering the streets, causing problems with their families, or going to health clinics. And this psychiatrist who worked in a public clinic was trained in Western medicine, obviously, knew that the need way outweighed the capacity, and thought about culturally appropriate intervention, and came up with the Grandmothers Program. And he trained, I believe it was a he trained 300 Zimbabwean grandmothers in cognitive behavioral therapy, and placed them on park benches or other open settings near clinics. And so people who once turned up at clinics or hospitals, rather than get put into a clinic, once the care provider heard the symptoms, you said, no, you need to go and talk to the grandmother. And like all good, textbook, storybook grandmothers, these women listened. They active listened. They provided shoulders if needed. They also provided, because they were trained in cognitive behavioral therapy, they also provided some feedback, and they provided resources. And care has turned around, and they are working their way away from the stigma of mental illness. It was so compelling that, since I'm old-fashioned and I actually read a newspaper because I like to touch it, I ripped that out and put it in my bag so I could take it to work and pull it out of PubMed to read the work myself. So this isn't just, we're not seeing this just in the United States when it comes to community, but we're seeing solutions on another continent that we could use here, because seniors are more active and living longer than ever before. I also think that we learned from the Horowitz Center publication this morning that there is a lot we don't know about how people who comprise a community access, consider, process, and make decisions based on the health information that they receive. That literature review showed that there are tremendous gaps in our professional knowledge base. And so I think a big step that we can make is for researchers who, including health literacy people, but not limited to those who solely define themselves as health literacy researchers, should actively seek out, and or vice versa, community-based organizations to partner together to advance the scientific knowledge of communities. Because if we don't understand how people perceive information, how they perceive health problems. I learned from that article yesterday that the word for mental illness that they're currently using in Zimbabwe translates roughly as thinking too much, because they got too much on their mind, right? They're bothered, right? And if researchers want to do research on people, people want answers to their problems. This literature search has shown us that there are gaps in the knowledge. So what is a much more logical partnership than putting researchers with community-based organizations to link future research participants with active researchers to fill in the knowledge gaps we learned about this morning? Michael?
No, that's a great idea, and I think there's a good amount of literature in the embedded researcher model that, in terms of just a quality improvement process for any of these interventions. So that's a great point. Thank you. And so our next question has to do with how can community-based health literacy practitioners connect and partner with clinical health literacy efforts? How can the two of these entities work together to lead better health outcomes? I know we've got some folks here who have talked about programs that are embedded in FQHCs, licensed community health centers. There's not necessarily a health literacy component among those, but there's hopefully folks working in communities can understand that at these delivery sites might be a good way to start. So who'd like to take our first stab at how this particular partnership between our health literacy community and community-based providers can work together? Yeah.
So we're the opposite. We're the clinical-based partnering with the community. So a few years back, we partnered with the Cane Ranch Institute for the Life Enhancement Program that you saw the slide of, and Dr. Andrew Pleasant, because you have to say it one more time in this room today. You're welcome. The statistics are really true. We really see great outcomes from this very concrete life enhancement program, health literacy program. When we partnered with them, though, we partnered and we did a formative research study with CRI and gathered some of our stakeholders in the communities, some of the community-based organization leaders, and we invited them to go through the program first. So have them experience it, have them go through the 12-week program. Half the program, we had about 10 community leaders and 10 regular participants go through the program together. And what we found was, boy, there's a lot of issues with health literacy. And we keep talking about the underserved areas, but there's a lot of issues with health literacy with people who have bachelor's degrees and master's degrees, who are really smart people, but they just are not involved in their own health and well-being. And I think that's a piece of the puzzle that's really, really important as we design programs going forward, is not to forget about these folks, especially as many of them now have high deductible plans, are paying extremely high costs for their insurance, and are afraid to use it. So we now have these folks that are walking around not sure what to do. So as we partnered with the community-based programs, everything from, you know, the local YMCA to the churches to running centers to mindfulness-based programs, we really tried to really sit back and listen. And that was really important for our organization, is to sit back and listen and to hear what's going on. But I think we have to keep in mind that health literacy is a concern for many, many people out there, not just the underserved.
I also think, just like we would want the community to identify the priority need, I think having healthcare organizations identify the priority need makes a difference. It's not, I don't think you can just go to a healthcare organization and say, hey, we can help you do something. And I think, you know, finding where the kind of synergy is between what they're looking to accomplish and what you are able to partner and bring to the table is really important. I also think that community-based, in terms of adult education, that's primarily my background. I speak to that adult educators sometimes forget that they have an expertise, and they are experts in adult learning theory and how adults learn, different ways of communicating, and this knowledge not only comes from a field of research, but also just experience, everyday experience of being on the front lines with adult students and learners in terms of how they're learning and the communication strategies used. And I think sometimes adult education shies away from, in a field that, you know, evidence-based research in the medical community is so very prevalent, and I think adult education sometimes forgets their own expertise in helping researchers and medical providers really understand communication strategies and learning approaches for adults. So I think that's one of the really important value that adult education can bring. And again, time building that relationship with the healthcare organization, and the understanding that sometimes your community intervention can fall victim to competing health priorities of an organization. So I know when we worked with actually Dr. Rudd's navigation program in a healthcare system, and they were very excited, and we were learning so much from our adult learners. For instance, we talked earlier about you know, that building that trust. First of all, we had to build that trust about really what the healthcare organization was going to take away from our adult learners as consultants. They question us, does this really matter? Does the healthcare community, are they going to believe what we say or implement what we say? So there was that piece of it. But all the things that we learned from the adult learners, and then translating that. But there were times when our work was really stymied by competing priorities of the healthcare organization, where we just kind of had to sit with the law and lose a little momentum because, you know, other things were going on within the hospital setting.
I've got three brief answers for you, Michael. The first is, I think we need to look toward every health, wellness, and/or literacy encounter as an individual opportunity to edify all three. For example, we learned this morning that teaching English as a second language can help people learn health information they never learned before. It also helps their numeracy skills, because if they learned cooking, I don't know if they learned cooking this morning with, you know, how do milliliters convert to cups and ounces. I definitely learned this morning that they learned about the difference between a teaspoon and a tablespoon of medicine, and perhaps you could overdose your kid, and that would be bad. But because they used health information to teach a literacy skill, they edified people's health and well-being, not just by self-report, but also from metrics with weight loss. I think that is tremendously important. And in the same way, I would say that although people may be hesitant to use their health insurance, if they do have a provider and they have a portal into that provider, those portals of mid to large health care systems have tremendous health education curricula for how to recognize wounds, how to see if you have Lyme disease or disease-specific interventions. For example, I was in a NIH workshop. Am I going on too long? Okay. All right. Then I guess I'll leave it at that rather than give you an example. What I would say for health systems, as well as anyone who runs, who is affiliated with online health information systems, those young people who have high deductibles, poor mothers, just about everybody in this country has a smartphone. And they look for information that way. And so if you are running some sort of health information site, you need to look at your analytics. What do people look for? What search terms do people look for? And what then do they click on next to get health information? That will tell you what your 21st century community needs are. And you also can look to search engine providers, many of whom are also providing the back-end analytics of your own websites. I'm not going to endorse any particular web search provider here as but that will tell you a lot about your community needs, because rich or poor, anybody who's raising a child, particularly if you have one in school, is going to have mobile phone access, even limited, because they're going to be available for their children. And so that smartphone can empower an entire family's health, literacy, and numeracy.
Okay, thank you. I think we got just a few minutes left. We have one last question here that I wanted to put out to the group, and this has to do with champions. And I know that we talked about this earlier, and I don't think any of us can overestimate the value of a good champion, from Dr. Wallington's Miss Betty to any of the other cultural brokers, the people who allow us access and entree and help to build that bridge of trust into the community. But when we talk about champions, this is kind of a tough question, because a lot of times we think of organizational champions, somebody who helps clear the way for policies and procedures, but that's just a very narrow definition. Within a community-based intervention, champions are those people who are really embedded in the community, or those who kind of help us to get into there. So how do we identify champions, or the role of a champion? Can we groom a champion? We probably have time for just maybe one or two folks with a quick response here, but who would like to take a jump here?
Take a quick jump.
Sure.
So we have both. When I was looking at this question, our CEO is our champion for policy and procedure changes. He found out that he had type 2 diabetes through a worksite wellness screening. President of a hospital, hadn't been to the doctor in 5 years. So he started drinking the seltzer and understood the wellness component and moved us very quickly forward into more of an integrative health model for our hospital and the work we're doing. Within our work with the community, and specifically through the Life Enhancement Program, these champions sort of float to the surface pretty quickly. They want to share their story. They want to talk about it. They want to go back into work and talk about it in the break rooms. So I'm going to continue talking. That was your timer. So, and we have quite a few of these champions that have risen to the occasion, and with great pride. And I think that's the component that you have to remember, is that this is really all about them and what they have succeeded in. So we've had one specific woman went on to become a well coach, she's a certified well coach now, and she has gotten a job in the WIC program, working in the community to bring knowledge, information, health literacy back out into her community through through learning more about it herself. So I think that there's plenty of opportunity for champions as long as they're given the opportunity to rise.
I'll just quickly add, I think we've had a bit of an unfair advantage with our champion. Senator Bill Frist is a singular individual, longstanding policymaker, along with being a heart surgeon and also having deep Nashville roots. So that really served to catalyze the community. I don't think we would have gotten the early momentum and positive energy without someone like that who people pay attention to. I don't think every group has to have someone of that stature. It's just someone who is credible, approachable, and who knows the issues.
So I think we're out of time for this panel. Are we going to go to roundtable discussion now? Do you want us to stay here?
Anywhere you want.
Let's go out to dinner.
So yes, that's exactly what we'll do. First of all, let me thank the panel for a very stimulating discussion.